We are now starting with the short talks in this session, and the first one up is Anish. I haven't memorized your talk title, so I have to wait until it pops up. Okay.
Awesome. Thank you. I want to thank the organizers for inviting me to speak. Today's talk, I'm a postdoc at Sloan Kettering in New York, where it's much colder than it is here. Today's talk is going to be on multiple myeloma, which I know a few of you here work on. But I'm basically going to show you a AI-based model to show that uses data that already exists in your hospital system to make a prediction from a precursor condition of a disease to the actual full-blown disease. So for the few folks who may not know what myeloma is a plasma cell cancer. It's somewhat rare in the US. I think the definition of rare, according to NIH, is 6 per 100,000, and this is 7. So it's just common enough to not be rare, but still very rare. The response rates vary quite a bit, as you can see. And we don't know exactly what causes myeloma. And so what makes myeloma, in my opinion, one of the most interesting diseases or cancers is that it has multiple stages that it starts with. So before you even get myeloma, there we go, myeloma, you can have these precursor conditions. And just because you're diagnosed with a precursor condition doesn't mean you're going to get myeloma. So for example, in this middle here is smoldering myeloma. The average over the age of 50 or in that population, about 0.5% of people have this disease, right? So if you have 200 people above the age of, 40, you have some number to, well, at least one person will have it. And so the thing is, we want to, but of that one person who has it, they only have a 10% chance, a bit less than that, of getting myeloma. And so it's very important to figure out who is going to get it. And it's important that if you know someone who's going to get it, that you treat them, which can be beneficial. But you definitely don't want to treat someone who's not going to get it. So hopefully, I've, in a very awkward roundabout way, I've phrased the challenge of why we care about this work, why it's important. Um, so I'm not going to go into too much of a detail of the myeloma staging systems, but they're basically, it's to say that the current systems that are used are based on baseline values for the first two. This is, you take the data you have at baseline, again, baseline diagnosis, and the newest model from Harvard has it, you look at changes in values, but only at 2 time points. And so these models, they're fun, but they don't seem to agree with each other. So the majority of the time, if you use more than one model, you'll put your patient in a different risk group. And this can be, this is mainly problematic because we only want to treat patients in the high risk cohort. And if you see how different the high risk cohort is from the study, your success rate is very low. So what's missing? We want to create a dynamic risk score. We want something that evolves every time a patient comes in. We want to capture patterns over multiple dimensions. And so one thing I forgot to mention is that when someone is diagnosed with smoldering myeloma, they come into the clinic every 3 months from when they're diagnosed for routine lab tests to make sure their myeloma hasn't worsened. So this means that for a patient who's been with a smoldering diagnosis for 10 years, you have 10 times basically somewhere between 2 to 4, maybe even 6 time points per year. So it's actually quite a rich data set. And so what we proposed to do was to create this method. At MSK, every AI method has to have some sort of acronym. I don't know why, but it does. So that's why this one is called CALM. And the idea here is we want to achieve 3 goals. We want to provide a risk score every 3 months. So basically matching what an ideal myeloma patient should come in for. We want to stratify them into zones. So kind of what you're talking about predictions, you want not necessarily exact data point, but I do have more than one parameter in this model. And then we want to make it very explainable. So we want to ensure that the physicians trust what we're doing. And so this is what the model looks like. This is my graphical abstract I use when I present to physicians. So there's no equations in this. But basically, what I want you to think is you have these lab values. These lab values are the ones that just exist in your hospital system. They're more or less what's being collected every time a patient comes in and blood is collected. So we have this data at multiple time points, and the AI model itself is extremely simple. It's just a vanilla LSTM, which is a long short-term memory network with a C-index function, Cox regression model, as the loss function. And at every time point or every 3 months, it makes a prediction. So for those who are not familiar with an LSTM, I like to say it's like how the brain works according to that movie Inside Out. New marbles or new memories or lab data, they roll in. The model decides, hey, this is important. We're going to keep this marble. Some is going to be like, this is very important. It goes in the vault. And others are like, oh, we no longer think this marble is important. And it just chucks it back out. So very much think joy, think inside out for this. Um, so I'm going to share some results with y'all super quick. So in this data set, these are all patients at MSK. We had about 400. This is the part I wanted to highlight. We have almost even distribution of risk scores that you see in this cohort according to sort of the gold standard of risk stratification. We have about 4 years of follow-up is the median and about 17 median assessments of the 400 something patients, a bit less than half progress to myeloma. And so when you pull EHR from Epic, you get everything. And so when we started with this list of about 30 lab values, we let the model pick which ones are the most predictive. And I only bring this up because if you have access to your hospital's EHR system, there's no reason why you can't do something identical. And so the model's C-index was fairly well. It did low 80s, which puts it at par or slightly above the current state of the art. But this is the part of it that I think is the most interesting. So for each patient, it produces this, what we're calling just a dashboard. So the bottom rows, right, bottom 2 rows with these colorful plots, those represent the actual lab values. I didn't smooth them or anything, just so you see how jagged they are. The y-axis is different for each one, which obviously you can't read from back there. But basically, the main takeaway is you have a bunch of messy curves, and the model takes all this data and makes a prediction every 3 months about this patient's risk. And so there are 3 risk zones: high, intermediate, low, that the model determines. And what you see is this patient, it started off as a high-risk patient. It gave it a higher risk score. But over as time went on and the lab value stabilized, it decided, hey, this patient's going to be all right. And it kind of did this a couple years before this patient's current status. So within basically 5 years of a smoldering diagnosis, it kind of started saying, hey, this patient's going to be all right. And so when you show this to a physician, the first thing they're going to say is, I don't believe you. And so the second half of this dashboard is a feature heat map. So this is calculated using integrated gradients, which is a very, I think, elegant solution to understanding how your AI black box works. The way to read this, and again, you can't read the label, so it doesn't matter too much, but is the x-axis is months since diagnosis. So this shows you like at what point where the lab value is collected. The y-axis are the features. And so what you see is that if it is blue, it means that it downweights the risk, and if it's red, it overweights the risk. And so if I put the 2 plots together, you can see that for this specific patient, it is the total M spike, or the sum of all the M spikes, that downweighted the risk. This is important because this changes per patient. So it's not always the total M spike or total spike that downweights the risk in a patient who's had myeloma for 10 years or smoldering myeloma for 10 years. It is different patient to patient because the model is learning trends that are not necessarily captured by just creating cutoffs for certain lab values. So I'm going to show an opposite patient. This is a smoldering patient who was diagnosed as low risk over here. And then at about 26 months into their time at Sloan, they were diagnosed with myeloma. Our model predicted it about a year ahead of time that they would get myeloma. And so why is this important? This is important because it gives people more time to make a choice, more time to figure out, do they want to get treatment at their center, at another center? Which treatment do they want to be prepared for? Just early diagnosis is important. And so once again, if you look at the feature maps, I'll put them together here. You see it's a different set of features that increase the risk. So it's really here, in this case, it's total protein and immunoglobulin G that upweight the risk, and it actually fights with the total M spike. which downweights the risk. And so the point of this model is to really show you that you can use lab data that you already have in your hospital, apply a very simple time series model, and actually predict time to treatment or response to treatment or time to next treatment, or any sort of time-based parameter without spending a dollar on data collection. And so I think this is, even if you're not doing myeloma, it's quite a useful way of thinking about your data. And so as I wrap up, I can just share this Kaplan-Meier curve on this new, we're already working on the next model. It splits quite well. And as you can see, it does a phenomenal job identifying the high risk group. And this is just based on the same LSTM-based risk stratification model. So with that, these are sort of my three takeaways. I think the simplicity of this hopefully matches. It's like consider it the one parameter model of AI, even though there's way more than one parameter in this model. So with that, thank you guys for listening to me. I work with all these great folks at Sloan. If anyone has any questions or time series data they want someone to look at, send me an email. Thank you.
Talk. Are there any questions? Oops. Okay, I'm coming. Thank you for giving me the opportunity to get my notepad to take notes. Great. Awesome talk. I did enjoy it. Thank you very much.
Thanks.
I have one question. Did you, by chance, also evaluate other performance metrics to determine how well this model really works?
Yes, so AUC, right, is the obvious, or C index, in terms of that. What we're doing is we're comparing it against previous stratification models. So if you're classified as risk 1 by system A, did you stay? How did that end up? And then say for patients that were misclassified by existing systems, how well do we do on misclassifications? And those are the sort of metrics that we're going after, because it's not necessarily about having the best accuracy. It's about being more accurate for the high-risk patients, because you definitely don't want to treat someone who is not really high risk.
Absolutely. So maybe just one point to look into. You do have the time to event data.
Yes.
I may be wrong, but if I understand it correctly, C-index just orders the patients relative to each other and does not identify the time points.
Absolutely.
It might be cool to use, I don't know. It looks super impressive, so I guess these performance metrics will be great as well, but some time to event performance.
I agree completely.
Yeah.
I agree. And also a validation data set I could also
Thank you.
It would be important.
Really interesting talk. Whoa, this is really echoey. I noticed that you have a series of time and then you have a prediction at the end. Did you ever stratify for time and see if the features selected change depending on where you are performing the diagnostic?
Yes, it does. Yeah. So it evolves over time. So the integrated gradient plots, I apologize, it didn't show up well on the slide. The x-axis shows you the feature importance by time step. So the features that are usually important in the first 2 years of a diagnosis tend to be different than the last 2 years. So it's like it's really the stability of M spike that drives basically a lower risk score for a patient, especially in the later time points.
Fascinating. Thank you.
So you mentioned this one patient where you were able to predict about a year early their progression to myeloma. What's the average on these high-risk patients, the lead time that is prediction?
I don't remember that number off the top of my head, but it varies tremendously based on their signal. So it can be a month, or it could be like a full year.
So based on your experience in the conversation between physician and patient, what is like the desired time frame? Like if you predict, oh, in 20 years something might happen, that's not as actionable as in 2 months something. So what's the window that you're shooting for?
So it's about so when people get the smoldering diagnosis, it's very anxiety provoking, because all of a sudden you have this disease which the majority of people have never heard of. And so there's if you can say you're in a high risk group, we think you might get myeloma in 6 months or 12 months, then you can say, okay, let's do some genomic testing, let's do a bone marrow biopsy, which you don't have to do if you're just smoldering. Bone marrow biopsies are somewhat painful. And so it gets the ball rolling. And if for someone whose your risk score is very low and they're say, I got my kid's birthday next weekend, I'm going to miss my appointment. Can I just go to my next one in 6 months? If it's a high risk patient, as a doctor, you're gonna be like, no, I still want to see you like the day after. But if it's someone who's very low risk, like, yes, I'll see you in 6 months, and I feel confident that you're going to be fine.
Well, thank you again. Great talk.